Hello everyone, this will be a short talk on radiotherapy for localized and locally advanced prostate cancer. So to understand this talk, you need to be familiar first with risk stratification. This is the EAU or DMECO risk group. It's easy to remember, but maybe not as helpful to clinical practice as the NCCN risk groups. So locally advanced prostate cancer refers to tumors that are T3 and beyond or are nodal positive cancers. There's more distinction in the NCCN risk groups. Categories for very low, intermediate favorable, and unfavorable, and very high disease. This slide highlights the differences, so make sure you're referring to the correct classification when selecting treatment for a patient. Just a reminder of the Roche formula, calculate the risk of extracapsular extension, seminal vesicle invasion, and lymph node involvement. One of the more important things I want to talk about is the proper assessment of patients for treatment versus watchful waiting. So the International Society of Geriatric Oncology, in collaboration with EAU, ECROP, and others, came up with a guideline to assess older patients to streamline their treatment. The main tools of assessment are the G8 and mini COG. These patients are then classified to fit, vulnerable, or frail based on how they perform in these assessments. The fit group is then given standard treatment. As for younger patients, the vulnerable group is a slightly gray area but can be given standard treatment. The frail group, however, should be given symptomatic care alone. All should also receive early best supportive care and adapted physical activity. So the G8 screening tool is a set of 8 simple questions designed to assess functional status, fatigue, comorbidities, cognition, mental health status, social support, nutrition, and geriatric syndromes. It's the gold standard of geriatric assessments. A score of 15 or 14 or less should be referred to a geriatrician for assessment. Mini COG is a clinical tool to assess the cognition of older patients. It can be done in the clinic in less than 10 minutes. So first you give the patient 3 words to repeat back to you and remember. Then ask them to draw a clock face with all the numbers and the hands pointing to 10 past 11. Ask them to recall the 3 words given to them earlier. If they score less than 3, they should be referred for dementia assessment. Just a quick reminder about bone health of patients on ADT. Please don't forget to advise patients on calcium supplementations and lifestyle modifications as recommended in NCCN. Weight-bearing exercises 30 minutes a day, stop smoking, and limit alcohol intake. So this is surgery versus radiotherapy. It's a very large and contentious topic and probably best saved for another day, another setting. But I want to take this time to talk about just one recent trial, PACE-A. The co-primary endpoints were patient-reported outcomes of urinary and bowel symptoms 2 years post-treatment. To sum it up, patient bladder incontinence was worse post-prostatectomy, bowel score was worse post-RT, and sexual scores were also worse post-surgery. So the decision for surgery, RT, or even surveillance should be tailor-made for each patient and discussed in MDTs. The Europrom surveyed close to 10,000 men with prostate cancer. The incontinence rate plummets once a patient has had a radical prostatectomy, with 35.5% using pads 2 years post-op and 59% post-op versus 33% post-RT reported leaking urine. Bowel symptoms, however, are more than double post-RT compared to RP. The sexual score was pretty miserable in both settings. So the Europress survey was done then to gauge the value of shared decision making. It found that higher levels of shared decision making are related to lower decision regret. It also found that higher levels of shared decision making is related to a better quality of life. So this is the point where I emphasize the importance of MDTs and shared Uro-Onco clinics for improved patient care. IMRT was a 3D CRT. So IMRT plus IGRT is the gold standard now. Large studies have shown that IMRT plus IGRT is superior to 3D RT. It allows for dose escalation, improving recurrence-free survival, and at the same time reducing gastrointestinal and genitourinary toxicities with dose painting and tighter constraints to those organs at risk. Dose escalation. The numerous trials have been carried out to determine the optimal dose of radiotherapy based on how high should we go in order to achieve the best biochemical control while still shying away from GU and GI toxicities. So this is a table of 6 large trials, an analysis of which was that at least 74 grays improves the rates of biochemical recurrence, disease-free survival, and disease-specific mortality while maintaining severe late toxicities at about 2 to 5%. A large propensity-matched non-randomized study of over 42,000 patients compared dose escalated versus standard dose external beam radiotherapy, divided into low, intermediate, and high-risk cohorts. So dose escalated RT was associated with improved survival in the intermediate and high-risk group, but not in the low-risk group. For every incremental increase of 2 grade, there was a reduction in the risk of death by 7.8% for the intermediate risk and 6.3% for high risk. So let's talk about dose escalation. The GTAC-18 recently published a phase 3 RCT investigating the role of dose escalation of EBRT from 70 to 80 grade in those with high-risk prostate cancer. And this was defined as the CT3 to 4, Gleason score of 8 or more, PSA 20 or higher. It was restricted to those with pelvic nodes that were negative on conventional imaging. All received ADT for 3 years and pelvic nodal irradiation to 46 grade. So just remember this population when we talk about adding adjuvant ARPIs later. The dose escalation significantly improved 10-year PFS by 10% and 10-year OS by 11%. Furthermore, there were no significant differences in the late toxicities or quality of life. I am showing you APCCC 2024 because APCCC 2026 has not published its results yet. And in APCCC 2024, there was a consensus reached recommending RT dose escalation to 80 gray for patients with high-risk disease. There are many ways to achieve dose escalation by boost to the dominant intraprostatic lesion or DIL. This can be done by EBRT boosts, brachy boosts, microboost in ultra-hyperfractionated RT, or even a combination of SBRT and brachytherapy. So what's the best way to dose escalate? There's no consensus even in APCCC. The recommendation is to design treatment based on patient and disease factors. Hyperfractionation. The rationale for employing hyperfractionation for the treatment of prostate cancer has been extensively studied, as slowly proliferating cells are more susceptible to higher dose per fraction. The definition of moderate hyperfractionation is below 4 gray per fraction, and ultra hyperfractionation is more than 4 gray per fraction. So several trials have been carried out to investigate moderate hyperfractionation in the low, intermediate, as well as high-risk population. All have shown non-inferiority in terms of biochemical failure, disease-free survival, and recurrence-free survival. And this table details the trials, risk groups, dose, and outcome. Currently, the prostate RT world is looking at ultra-hyperfractionation as the way to go. The potential benefits are radiobiological superiority, less time for patients in hospitals, reduced costs, and less machine time use. Of course, these pros must be weighted carefully against possible risks. The HYPO-RT-PC trial randomized patients with intermediate and high-risk prostate cancer to conventionally fractionated RT or an ultra-hypofractionation regime, and they used 42.7 gray in 7 fractions every other day. The 5-year failure-free survival and acute GI toxicities were the same in both groups. PACE B is a randomized trial of almost 900 patients with low and intermediate favorable risk prostate cancer. They either receive conventional or moderately hyperfractionated radiotherapy or ultra hyperfractionated 36.25 gray in 5 fraction every other day. Acute toxicities in both arms were similar, and the updated analysis showed that biochemical event-free rate was non-inferior. And this shows that the long-term GU and GI toxicities, as well as quality of life, was similar between both arms. Meta-analysis, of course, was carried out across 38 trials and includes those with low, intermediate, and high-risk cancer. It shows a 5-year biochemical recurrence-free survival rate of 95.3% and severe late GU toxicities at 2%, GI toxicities at 1.1%. So ultra-hypofractionation seems poised to be the standard of care for low and intermediate risk prostate cancers. So what about high risk? What does the evidence say? This is the SHARP consortium. They ran an analysis on patients with high-risk prostate cancer receiving ultra-hypofractionated treatment. The biochemical recurrence-free rate was 81.7%, and distant mets-free survival was 89.1%, suggesting that ultra-hypofractionated therapy can be employed for high-risk patients. They also found that on multivariate analysis, 8 gray per fraction was superior to 7 gray per fraction. The PACE C toxicity results were reported, and this is a trial that recruited 1,208 men with T1 to T3E prostate cancer, Gleason score 8 or less, PSA 30 or less, and randomized them to SBRT 36.25 gray in 5 fraction or moderate hyperfractionated RT. 35% of these patients were considered high risk, with 28% having T3A disease on MRI. On a side note, only around 40% were treated with fiducials and 85% were treated on conventional Linux. So the acute GU and GI toxicity was measured using RTOG and CTCAE grading. For acute GU toxicity, there was no significant difference. For acute GI toxicity, SBRT did 7% worse than moderate fractionation, but there was no difference seen in grade 3 toxicities for both GI and GU toxicities. In the PRIME trial, there were 307 high-risk or nodal positive patients with prostate cancer randomized to moderate or ultra-hyperfractionation. Both arms received long-course ADT, and it found that there were no significant difference in the GU and GI toxicities. All toxicities were fairly similar across the board. Efficacy data for this trial is not out yet. So based on this data, NCCN recommends moderate and ultra-hyperfractionated schedules for low, intermediate, high, and very high prostate cancers. APCCC, most experts favor moderate to ultra hyperfractionation. There is still a tremendous debate among experts, especially after the publication of PACE B. The efficacy of SERT and moderately fractionated radiotherapy are similar, but there is numerically added toxicity. So some experts argue that treatment that potentially causes more harm should not be prioritized. However, the Lancet Oncology Commission for Radiotherapy and Theranostics was created to assess radiotherapy, especially in view of the availability of machines in low and middle income countries. So this commission investigated initiatives that could mitigate this, such as extended treatment hours, hyperfractionated RT protocols, and new technologies. Ultra hyperfractionation compared to moderate hyperfractionation in a lot of cases is equally efficacious. There's no significantly worse toxicity. It reduces patient visits to the hospitals, frees up machine time, and therefore shortens waiting times and affording hospitals the ability to treat more patients. So is this the answer to all non-metastatic prostate cancer? Maybe not, but a lot of research is being done to determine the best approach in each situation. So do we radiate elective nodes in most patients? There is increasing interest in this area using conventional as well as hyperfractionation. The RTOG trial shows that elective whole pelvis RT in high-risk patients significantly improved PFS, but there were more grade 3 GI toxicities. The pivotal POP RT trial showed that in high-risk patients, elective pelvic nodal radiation causes significant improvement in biochemical freedom-free survival, disease-free survival, mets-free survival, but not in overall survival. There does appear to be a benefit for radiation of the pelvic nodes if the patient is nodal positive. The toxicity data for pivotal boost was just reported. These patients received RT to the prostate, a boost plus pelvic nodal RT. There was some increase in early bowel side effects, but no difference at 2 years. SHARP Consortium, a multinational database of patients with prostate cancer, investigated the pooled outcomes of SBRT for high-risk patients given 35 to 40 grays to the prostate and 25 gray to the pelvic nodes, all in 5 fractions. So the overall pelvic control was 98.2% with a 5-year biochemical failure-free survival rate of 86.1% and overall survival of 89.3%. So based on that, the PACE notes is a phase 3 RCT now underway to confirm the safety and efficacy of prostate plus pelvic nodal SBRT for high-risk prostate cancer. There are a number of other trials testing ultra-hyperfractionated elective pelvic nodal doses as well. In APCCC, most experts agree that at least some patients with nodal negative prostate cancer should receive RT to the pelvic nodes. Node positive patients. Historically, we treated high-risk prostate cancer with long-term ADT plus local therapy plus ARPI or RP plus elective pelvic lymph node dissection. But with modern techniques, we have been treating these patients radically. There's a mountain of evidence to support local treatment for nodal positive patients, including an arm of the STAMPEDE trial, showing that the addition of EBRT to ADT in node positive patients improved the 5-year survival by more than 20%. This is the APCCC consensus statement, where there's a strong consensus in favor of RT to the prostate plus pelvic lymph nodes, in addition to long-term ADT and 2 years of abiraterone in this group of patients. So the EAU recommendation is to stage with a PSMA PET along And along with prostate RT, as described earlier, the elective nodes should be radiated to 45 to 54 gray, with gross nodes receiving 60 grays in EQD2. These patients should receive long-course ADT. So ADT and localized or locally advanced disease. Many studies have been conducted to determine if there is an indication for neoadjuvant, concurrent, or adjuvant ADT. Early studies gave short-course ADT even in high-risk patients with not much improvement in outcomes. Later studies show that certain durations of ADT have improved biochemical-free survival and cancer-specific survival. So to summarize the recommendations, for low-risk prostate cancer, no ADT is required. Intermediate favorable, there's no clear indication but should be considered by patient. In intermediate unfavorable risk, patients should be given short-course ADT for 4 to 6 months, and in high risk, they should receive long-course ADT for 2 to 3 years. The prognosis for high-risk prostate cancer, despite the use of dose-escalated IMRT and long-term ADT, still leaves room for improvement. So studies have been carried out to further intensify treatment with androgen receptor pathway inhibitors. So a stampede meta-analysis of patients with high-risk prostate cancer, i.e. node positive or node negative with at least 2 other high-risk factors, were given radiotherapy and then given ADT for 3 years with or without abiraterone, with or without enzalutamide. And the intervention arm showed improved mets-free survival and overall survival with no difference of the addition of enzalutamide to the abiraterone arm. Based on this, the ASTRO-ACROP recommends adjuvant abiraterone for 2 years and ADT for 3 years in high-risk and very high-risk patients. So similarly, the ENZARET trial is an Australian trial giving adjuvant enzalutamide to high-risk patients post-RT. It was a negative trial with no MFS, PFS, or OS benefit. The critique about this trial was that the population was of significantly lower risk than the stampede population. But based on a pre-specified subgroup analysis, the benefit for nodal positive patients is also positive in the ENZARET trial. The Darius Jitac study is underway investigating the role of darolutamide concurrent with radiotherapy. So in APCCC, 68% of experts would offer ADT plus abiraterone in addition to radiation for patients with high and very high risk localized or locally advanced prostate cancer. How about proton therapy? So a recent RCT compared equivalent doses of proton beam RT versus photon EBRT, and there was no significant difference or improvement in terms of toxicities. So lastly, let's talk about common toxicities and how to mitigate, cope, or treat them. These are the common toxicities that we usually see after giving prostate radiotherapy. Urinary cystitis can be due to fibrosis, can be due to inflammation, it can be due to damage to the urothelium and detrusor. And this generally creates urinary frequency, overactive bladder, or reduced functional capacity. It can also cause narrowing of the urethra, leading to obstruction, and radiotherapy can also cause weakened pelvic floor muscles. So how do we mitigate? With pelvic floor exercises, hydration, avoidance of caffeine, alcohol, and carbonated drinks, continence products such as absorbent pads or penile clamps, and surgery. A more important side effect of radiotherapy would be radiation proctitis caused by inflammation, fibrosis, and injury to a nerve and muscle. So in the acute phase, it can cause diarrhea. In the late phase, it tends to cause bleeding. We can mitigate this with low fiber diet, hydration, anti-inflammatories or stool bulking agents, and rectal spacer as shown here. When a rectal spacer is inserted, it causes distance between the prostate and the rectum, and so the high dose from radiation does not reach the rectum at all. Sexual side effects such as erectile dysfunction, loss of libido, and urinary leakage can be treated with medication, vacuum erection devices or implants, and therapy. So what do guidelines say by risk stratification? To sum up, these are the treatment recommendations based on current guidelines. For low or very low risk, depending on life expectancy, either watchful waiting or active surveillance. For intermediate risk, observation, prostatectomy, brachytherapy, or EBRT. SBRT is a good option here. Most patients will also require short course ADT. For high risk, prostatectomy, RT, consider moderate hyperfractionation or SBRT with or without elective pelvic nodal radiation with long-term ADT. For very high risk, RP is still an option, but likely combined with adjuvant or early salvage RT or EBRT plus long-term ADT and ARPI. So I leave you with this slide that sums up current advances in treating localized and locally advanced prostate cancer. Thank you.